Now let me invite Dr. Dhanya RS, Associate Professor of Ophthalmology, Alapura Government Medical College, as she demystifies pediatric retinal mysteries, ROP and beyond.
Good morning, one and all. Thank you, Divya, for this opportunity. So, today morning we'll discuss about a handful of pediatric retinal conditions. It's not going to be a very elaborate talk because there are so many conditions which are very familiar for all of us. So, there are a handful of situations which you see when you are evaluating a child, a baby, a newborn. First of all, we'll go to the most important thing, that is the retinopathy of prematurity. As you all know, it is a vasoproliferative disorder of the immature retina, and the abnormal vessels will grow, and it may lead to, if not intervened in time, it will lead to retinal detachment and blindness. So, this is a very important slide. I want you to listen carefully, because in the normal intrauterine growth, there is a natural hypoxia which is responsible for the physiological normal vessel growth in utero. Now, what happens when there is a preterm delivery? There is an arrest, and immediately there is a phase 1, that is a hyperoxic phase, that is the baby is exposed to the atmospheric oxygen, and also during the golden hour there will be a resuscitation by the neonatologist, which will also produces immediate hyperoxia, which will suppress the VEGF, arrest the vessel growth. That is a phase 1. And second phase is a phase of hypoxia, where there is an excessive VEGF which will lead on to the abnormal neovascularization, fibrosis and tractional retinal detachment. Now, the most important risk factors are prematurity and low birth weight. In addition to these, the other risk factors include anemia, sepsis, the high exposure to oxygen, especially during the golden hours of life, and then other cardiac defects, history of multiple blood transfusions, and the respiratory distress syndrome. Now, whom to screen? Now, we cannot screen all the babies, so whom do you screen for ROP and when to screen? These are two very important questions. So, as per our RBSK guidelines, we have to screen all babies less than 2 kg and any baby less than 34 weeks, and all babies between 34 and 36 weeks with risk factors, a huge list of risk factors as you can see, and any baby who is determined to have high risk, is told to have high risk because of their unstable clinical course by the neonatologist or pediatrician. So, these are the babies whom you have to screen for ROP. Now, when to screen? The ideal time for screening for ROP is at 4 weeks of birth, as madam said, the 30 din roshne ki. So, you have to screen all babies, all preterm babies at 4 weeks of birth. And any infant with a period of gestation less than 28 weeks, they may be seen a little bit earlier, because 4 weeks it will be like delayed. So, you see them at between second to 3 weeks, second to third week after delivery. Now, how long will you follow up these babies? First is, if the retina, till the retina becomes completely vascularized, or if there was an ROP, when the ROP becomes fully regressed and there is no signs of any risk of visual loss. This usually happens between 40 to 42 weeks. So, follow up the babies till around 42 weeks if the vascularization has grown and it is okay. And the third one, if the ROP has progressed and you have decided to treat this baby. How frequently can you follow up these babies? Now, if there is no signs of any ROP, it is safe to see these babies every 2 to 3 weeks until the retina is fully vascularized. And if any ROP is present, the important thing is, if it is a zone 1 ROP in a stage 1, 2 or 3, without plus disease. If there is plus disease, immediately you are going to treat the baby. But without plus disease, see the baby at least weekly or even a shorter duration. So, it is better to see if it is a stage 2 or 3, see the babies every 48 hours or 3 days or something like that, as you feel like. Okay. So, don't take that risk of not seeing the baby. And if it is in a zone 2 disease with immature vascularization, or it's a stage 1, 2 or 3, then you can follow up the babies weekly or 2 to 3 weekly. Now, This is a recent classification which we have to follow, that is the IC ROP 3 guidelines. So when you screen a baby, you have to look into all these headings. So you have to classify each eye based on the zone, whether there is a plus disease, what is the stage of the disease, what is the extent of the ROP disease, and whether AROP is present or not. So we go into each of these. So what are the zones which we have to look into? There are 3 zones, as you all know, the zone 1, 2 and 3. And what is zone 1? That is a circle centered at the optic disc, not fovea, at the optic disc, with a radius twice the distance from the disc to the fovea. That is zone 1, the most important. Now zone 2 is a centrifugal extension from the edge of zone 1 up to the nasal ora serrata, and the remaining crescent which is present in the temporal half forms the zone 3. And there is one important point that you have to notice here, that is a zone 2 posterior. What is a zone 2 posterior? It's an area which is 2 disc diameters extending from the border of zone 1 into zone 2. That is a zone 2 posterior disease. And how do you classify the extent of the disease? The extent is determined in clock hours as based on the 12 sectors of the clock hours. So these zones are very important when you are seeing a baby. That is a zone 2 posterior. Now, one important thing that you have to know is what is a notch. Notch is an incursion of ROP lesion of 1 to 2 clock hours into a more posterior zone. Now, suppose you see that a baby is mostly the retina has reached up to the zone 2, but 1 to 2 clock hours of the temporal retina, it is having a notch into the zone 1. Then you have to mark it as zone 1 secondary to notch. Now, this is an important definition that was made by the ICROP. Now, next is plus disease spectrum. Now, what is plus disease? That we are all well aware of, and you should know the criteria when it is called plus. That is, there should be increased venous dilatation and arterial tortuosity of the posterior retinal vessels. When you look at the posterior pole, the posterior retinal vessels should have dilatation and tortuosity, and at least 2 quadrants must be involved, and it may be associated with iris vascular engorgement, a rigid pupil, a non-dilating pupil, or a vitreous haze. Anything less than this has to be classified as pre-plus, and if you suppose you are seeing a baby, there is some arterial tortuosity, some venous dilatation, but it's not meeting the criteria, closely follow up the babies, because there is high chance that this baby will go on to a plus disease. So there is, see, these are 2 pictures of the same fundus. You can see that initially maybe there is a pre-plus slightly, but it has become a plus. Now, the third thing is what is the stage of acute ROP. So initially we'll see what are the stages 1, 2 and 3. Now, stage 1 is a faint demarcation line between the vascular and avascular retina, and stage 2 is a ridge. Stage 3 is extraretinal fibrovascular proliferation, which will be elevated, raised into the vitreous. And this fundus is also showing plus signs. There's a plus disease with a stage 3. Now, what is APROP, or recently now we call it as AROP, or the aggressive ROP, which is a rapidly progressive form of ROP with prominence of plus disease. Vascular loops hemorrhages usually occurs in the smallest and most immature infants. And this is sometimes it may be overlooked because of the very feeble presence. So we may miss it. So those babies also, if you are suspecting an AROP, you closely watch these babies. And stage 4 and 5, it is like the severe forms of ROP that is associated with retinal detachment, and stage 4A is an extrafoveal ROP and 4B is foveal ROP. And if it is a total retinal detachment, it goes to stage 4. So these are the different stages of ROP. Now, how do you manage ROP? There are various methods, that is depending upon the stage. In type 1 ROP, what is type 1 ROP? You have to administer peripheral laser ablation, and type 1 ROP is defined as any stage of ROP with plus disease in zone 1, stage 3 ROP without plus disease in zone 1, and stage 2 or 3 ROP with plus disease in zone 2. So it's better to, this is the time when you decide to treat the baby, and once you have reached this stage, it is immediate laser ablation. Don't delay for any longer period. So you have to plan a laser treatment at the earliest. Anti-VEGF agents are also being used now, especially for AROP as well as stage 3 ROP with plus disease in zone 1. So this is very important. The stage 3 with plus disease in zone 1, you buy time for doing laser. And you also get to see that once you give the anti-VEGF, there will be slightly more improvement in the retinal vasculature, and also you can delay the laser procedure by around 3 to 4 weeks. So by the time the retina would reach up to a zone 2, and so the rest of the retina you can ablate with laser. Two more important headings that we have is regression and reactivation. Regression, it can be complete or incomplete, and there can be a persistent avascular retina, and sometimes the ROP can reactivate, and you have to record it as a reactivated stage 2. So ROP is in preterms, but term babies will have FEVR, and if ROP FEVR-like features seen in preterm babies, you call it ROP. These are some new terms coined. Now, after ROP, we'll just brush through some relevant topics. That is, one is FEVR, which is as you know, it's a autosomal dominant condition seen in high myopes. The patients are usually asymptomatic to the extreme. Some patients can develop unexplained, may present to you with unexplained neovascular glaucoma also, children. Now, this is a classification characterized by temporal, peripheral avascular retina and some vascular abnormalities lead on to retinal detachment. Now that is the FFA, that you can see the avascular peripheral retina as well as the macular dragging or ectopia. How do you treat? The treatment is mainly by laser photocoagulation, and in advanced cases may require vitrectomy surgery. Next disease is Coats disease. This is also seen in children. Unilateral, typically presenting with retinal telangiectasis and severe exudations. This also responds well to laser photocoagulation. So you can see that the laser has very well regressed the lesions, and the exudations have also resolved. Another condition called bilateral Coats associated with systemic condition is called Coats plus disease. Lethal condition, it's a severe disease associated with skin condition is incontinentia pigmentosa. It also presents with peripheral avascular retina and telangiectatic vessels, which you may encounter during your screenings. And this condition, we usually in ROP babies, when you screen babies for ROP, you come across this condition, that is the persistent fetal vasculature, that is incomplete regression of the primary vitreous. It's also typically unilateral. This is seen in full-term infants, usually without systemic conditions. It can be anterior or posterior, and the anterior, as you can see, there will be the leukocoria-like appearance with persistent pupillary membranes, and posterior PFV may be associated usually with a hypoplastic optic disc. Norris disease is a severe phenotype of the spectrum of NDP-related retinopathies, where there can be blindness at birth or in early infancy. You can see the small microphthalmia. The CT also shows the bilateral microphthalmia. Leber's congenital amaurosis, characteristically you get the oculodigital syndrome in this condition, and blindness can happen by 1 year, and there will be a typical extinguished ERG in this condition. This is one common entity that you should know about. Torch infections can present as varying manifestations in the retina. This is the salt and pepper retinopathy. And another relevant condition is ocular toxocariasis, that can present as a peripheral or posterior granulomas associated with endophthalmitis, and it will very well respond to albendazole with steroids. Viral uveitis is also not uncommon. And this is the shaken baby syndrome. See, some baby, if you have follow-up coming with multiple retinal hemorrhages and you don't see any particular indication, you cannot, so you have to think about this condition also in our society, in this period. So there will be multiple hemorrhages and all. And to end with, I'll just put one slide on retinoblastoma. That's a very relevant topic. I don't have the time to discuss about it. Some points, that is, one is prenatal testing for RB1 mutation. It is very important if the parents are having a family history of retinoblastoma. Super selective intra-arterial chemotherapy with melphalan. It's a frontline standard now. And intravitreal chemotherapy with melphalan will take care of the vitreous seeds. And aqueous humor biopsy will give you the tumor DNA. You can identify the tumor DNA, and targeted radiation. Previously it was the external beam radiotherapy. Now it is a targeted and novel radiation, reduces the recurrence as well as the take care of the margin of the lesions. Thank you.